Hello, everyone. Welcome to BrainMap. This seminar series is co-sponsored by the P41 funded Center for Mesoscale Mapping, housed in the Martinos Center. It is our great pleasure today to have Dr. Jessie Fu for giving us BrainMap talk. Dr. Jessie Fu is an instructor in radiology at the Massachusetts General Hospital and Harvard Medical School. Dr. Fu's research focuses on the translational application of multimodal neuroimaging and multivariate analysis in neurodegenerative disorders. Dr. Fu is principal investigator on NIH NIA K99R00 award for identifying novel composite score for digital clock drawing tests most correlated with the underlying pathophysiology of Alzheimer's disease measured by like PET and MRI in order others without clinical cognitive deficit. Dr. Fu completed her undergraduate and graduate degree in physics at the University of British Columbia under the mentorship of Doctors Vassilossi, Martin McKeown, and John Strozel. Her PhD research involved developing and validating novel multivariate analysis for extracting spatial patterns of neurotransmitter PET outcome more sensitive to the progression and initiation of Parkinson's disease. In late 2020, Dr. Fu joined Doctors Julie Price and Kate Johnson's group at Athinoula, a Martinos Center for Biomedical Imaging, focused on evaluating the in vivo kinetics of the second generation tau PET radio tracer MK6240 to improve early tau detection in Alzheimer's disease. She has served as a guest editor for Frontiers in Aging Neuroscience and is a review editor for Frontiers in Brain Imaging Method and Frontiers in Nuclear Medicine, Physics, and Data Analysis. Dr. Fu has also received Young Investigator Award from the Neuroreceptor Mapping and the Society of Nuclear Medicine and Molecular Imaging conferences. She co-chaired the PET methodological session at BrainPAT 2019 and the Translational Human Studies subcategory at the 2024 World Molecular Imaging Congress. I would like to remind our audience to address their question in the Q&A box or by raising their hand. The stage is yours.
Thank you so much for the intro. It's relatively long, but thank you so much for the opportunity to present some of our recent and ongoing work in Alzheimer's disease. So we'll be focusing on in vivo evaluation of PET radioligand kinetics, and also some recent finding for my K99R00 project on the digital cognitive assessment tools. I actually have also one slide about myself. So as Chuhyun just said, I obtained my PhD degree in physics, specializing in medical physics from the University of British Columbia, that's in Vancouver, Canada. And my PhD was really focusing on implementing multivariate analysis or traditional machine learning to analyze multi-tracer PET imaging data in Parkinson's. And in late 2020, Drs. Julie Price and Keith Johnson has been my mentor for my postdoctoral training. And last year, I got a K99R00 award focusing on a digital cognitive assessment tool. And this is really under the mentorship of many colleagues at Martinos Center and also MGH Neurology. So here's a quick outline for the talk today. So in the first part, I'll be talking about quantification of the second generation tau PET radioligand MK6240, and dividing into two parts. So part A is really quantifying the in vivo kinetics and also longitudinal stability of this extracerebral off-target binding signal. So this signal is not binding to tau, but it's off-target. And the second part is our work on assessing early phase of dynamic MK6240 PET as a potential surrogate for cerebral perfusion using PET-MR. And then some preliminary results from the K99R00 project, focusing on the evaluation of longitudinal performance of a novel digital clock drawing test for detecting early cognitive decline related to tau and amyloid beta. Okay, so a little bit about tau pathology in Alzheimer's. So tau burden is highly associated with neurodegeneration and cognitive decline. And in Alzheimer's disease, its tau deposition spreads from the entorhinal cortex to other cortical areas under the influence of amyloid beta. And in the figure here, you can see the tau spread pattern from a cognitively normal older adults all the way to someone with Alzheimer's disease. And you really see tau burden across all the cortical regions. And tau PET imaging has a potential to facilitate more accurate diagnosis, precise assessment of disease severity, and also assessing disease-modifying anti-tau treatment, and it can potentially also inform patient enrollment in clinical trials. And here's a brief list of some of the tau PET radioligands that has been developed over the years since 2013. And there has been a lot of efforts to improve the sensitivity to detect the earliest tau deposition as a research direction moved towards early disease detection or even preclinical AD detection. And if we focus on two tau radioligands in particular, the flutalsapir or AB1451 currently is the most commonly used first-generation tau PET radioligand developed by Siemens. However, it shows relatively high off-target binding in the basal ganglia, which can decrease the sensitivity for us to detect early tau burden or longitudinal change in tau. And to address some of these limitations, second-generation tau PET tracer MK6240 was developed in 2016, which showed a higher affinity to tau proteins, potentially allowing us for higher sensitivity to detecting small changes. And since the development of MK6240 in 2016, several centers have begun their human studies to evaluate the in vivo kinetics in both Alzheimer's participants and also cognitively normal individuals. And two recent MGH studies really focus on addressing some of the technical challenges that were not fully examined in the first round of in vivo evaluation. So before moving on to more specific research results or research projects, I want to go over one slide overview about kinetic evaluation of a novel radioligand. So for a dynamic PET study, so for example, for MK, it will be a 2 hours dynamic study after the time of injection. We can plot the time activity curve here. And this is an example of a Alzheimer's participant where you see high activity in a target region, such as the entorhinal cortex, and relatively low activity in the reference region. That is our background signal. So we want to correct for non-specific free uptake. And for novel radioligand spectral analysis is often used to estimate the compartmental configuration by evaluating the radioligand's kinetics. And for MK6240, a two-tissue compartmental model is the most appropriate. So we have the plasma compartment, that is the PET activity in the arterial blood. And also two tissue compartments, the non-displaceable and specific binding compartments, so two tissue. And several physiology parameters can be derived from these compartmental models. For example, this K1 parameter, so the rate constant of radioligand transferring from the plasma blood across the blood-brain barrier into the brain tissue, which is proportional to cerebral perfusion. And the distribution volume, VT, which is the ratio of tissue concentration and plasma concentration, give us an estimation of their tau burden. And when a reference region can be identified, so the reference region should not have specific tau uptake, we can simplify the analysis using a reference tissue model, without you need the need of arterial sampling. And here we can also estimate parameters such as relative delivery indices R1, which is a K1 in a target region or a K1 in a reference region. And for studies without dynamic acquisition, all of the previous methods required dynamic acquisition. For studies without dynamic acquisition, the simplest method is standardized uptake value ratio or SUVR. And that can be estimated as the ratio of a PET activity in a target region over a reference region over, like, say, 20 minutes time window in late scan. So for MK6240, it will be over 90 to 110 minutes. Okay, now moving on to our first study. So this is the evaluation of the kinetics and also longitudinal stability of the extracerebral off-target binding signal. And this is in close collaboration with our colleagues from the Gordon Center, especially Christina Louise and Keith Johnson. So imaged on the left, we have the MK6240 SUV, or standardized uptake value images for a mild cognitively impaired participant, showing high tau binding in the temporal cortex, and for a cognitively normal older adult. And you see for the cognitively normal adult, there's this very high off-target binding in the extracerebral region, so right outside the cortex, and that is not tau. And if we estimate our SUVR outcomes, the SUV in a target region over a reference region, the spill-in contamination from this extracerebral off-target binding can spill into the reference region. So the cerebellar gray matter, that's what we use for tau, and also the target region, the temporal cortex, or interrhinal cortex. That's where we really want to detect early tau burden. And this can potentially reduce our sensitivity to detect early tau burden. And the in vivo kinetics of this off-target binding signal is still unclear. And if you look at longitudinal studies using MK6240, recent studies has reported annual increases of target region SUVR to range from 0.02 in cognitively normal individuals to 0.15 in Alzheimer's participants. However, studies on longitudinal stability of this off-target binding signal are quite limited, and all of these evaluation is especially important for the detection of emergent tau signal in early, even preclinical or pre-symptomatic Alzheimer's disease. So in this particular study, we recruited 32 participants in total. Majority of them are cognitively normal older adults, and we have 8 participants with MCI or AD, and all participants underwent dynamic MK6240, and 13 of them underwent arterial sampling. And a subset of participants underwent longitudinal follow-up at 6 months, and a subset underwent follow-up also at 1 year. And we applied spectral analysis to really examine the kinetics of extracerebral signal and also some of the reference regions. And we also estimate the longitudinal change of the extracerebral signal, also some reference regions using the change in SUV at 6 months and at 1 year. So we first use spectral analysis. So we really want to learn about the kinetics of this off-target signal. Does it follow what we know about specific tau uptake? So with spectral analysis is a data-driven method that can describe tracer tissue exchange without any assumption on the type or number of compartments necessary to describe the data. So we first applied the spectral analysis to a reference region, and that is the cerebellar gray matter that is used for tau PET. And we identified 2 distinct reversible compartments consistent with a 2 tissue compartment configuration. So as I said before, there are 2 tissue compartments, and you see this high delivery component from spectral analysis and a late, slower reversible component. And it's maybe a little bit hard to see, but there's also this little green line here that indicates the presence of irreversible binding or trapping component. That is when K4 equals to 0. So once the ligand binds to our specific targets, it can now reverse back to free radioligand. And if we look at the kinetics of this off-target binding signal, we saw that there's a single reversible component, this delivery phase, and a large contribution of this irreversible or trapping component. And you see the shape of this kinetics of the off-target binding signal is very different from what we see in the reference region. And this suggesting that this off-target binding signal has really different kinetics compared to our specific and non-specific NK signal. And maybe the level of this trapping component, so the green line here, can potentially be used to estimate off-target binding signal contamination in our reference region and target regions. Yeah.
In that model, your plasma concentration is that fixed Or is that also something you force? How do you model?
Yeah, so it is a fix. It's used as an input to the model. Yeah, so for some of these analysis, we would require the use of arterial sampling, so arterial input function. So this is input. Yeah, so if we look at some baseline characteristics of this off-target binding signal, so at baseline, we saw this off-target binding signal was similar across groups. So cognitive normal or ADMCIs, it's not like patients with Alzheimer's show higher off-target. And we did not see any correlation with age or sex. And at the group level, this extracerebral longitudinal change was similar across diagnostic groups with similar magnitude, but larger intersubject and intrasubject variability compared to our reference regions, such as the cerebellar gray matter. And since the target region SUVR change may be in the range of 0.02 per year, in cognitively normal individuals, this high longitudinal variability in this off-target binding signal can really impact our ability to detect a robust tau change in preclinical AD and potentially in clinical trials targeting early Alzheimer's disease. So the remaining challenge is, first, how do we quantify the level of this off-target binding signal in different subjects? Since we know that not every single subject show this off-target binding signal, some people have very high signal and some people don't have this signal at all. And also in different regions, because it is in this extracerebral space, regions that are closer to the extracerebral off-target may be more affected by this contamination. And the second challenge is, can we really tease out this off-target binding contribution from our target and the reference region uptake? And we recently presented this work at neuroreceptor mapping. We attempting to address these issues using compartmental models. And we propose to add a extra term, this S plus CS term, where S is the fractional contribution of the extracerebral signal in a tissue. And for example, this tissue can be the entorhinal cortex. And the CS here is our activity in the extracerebral signal. So by modifying the compartmental models, we hopefully can potentially tease out extracerebral contamination from our target tissues and also reference regions. And this is a preliminary results, very limited sample size right now, but there's a quick slide on the results. But so this is an example results for cognitive normal individuals with very high extracerebral signal. So in this particular subject, we wouldn't expect any specific tau uptake in the target regions. It's really contamination from the extracerebral off target. And in panel A here, we show that if you look at the time activity curve for the extracerebral off target binding, we confirm it keeps increasing, indicating irreversible binding behavior. So in K4 of that two tissue compartment model equals to 0. And if we look at the target regions, the B and C are both for entorhinal cortex, our early tau deposition region. If we use a conventional two tissue compartmental model, the tau estimation is for VT is estimated to be 9.8, and DVR, so VT normalized by a reference region, is about 1.01. If we correct for the extracerebral contamination using our modified compartmental models, you see the decrease in VT. So VT specific tau uptake to 2.4. So really we bring down the uptake in this particular subject, potentially because we're reducing the contamination of the extracerebral signal in the entorhinal cortex. Some quick update here for this part of the analysis. So the extracerebral uptake at a group level is stable over 1 year, but really showed high longitudinal variability independent of the diagnostic groups. So no matter they have Alzheimer's, MCI, or cognitive normal, pretty high longitudinal variability. And this extracerebral signal seems to show very unique kinetics compared to our reference region and also target region uptake. And in spectral analysis, we saw this trapping component. So K4 equals to 0, indicating irreversible binding kinetics in this off-target binding signal. And potentially this level of trapping component in target and reference regions can reflect the level of extracerebral contamination in the regions that we do care about. And we can potentially use this unique kinetics of this off-target binding signal to reduce the extracerebral contamination in our target and reference regions to further improve quantification for early tau deposition. Okay. Yeah, so now moving on to a study using the PETAMAR. So this is data that we collected on Bay7 in close collaboration with Maher and Cyprian. So this part is looking at longitudinal MK6240, this early phase of that dynamic PET acquisition provide us some estimates of cerebral perfusion. So previously I have been talking about tau deposition a lot. So, but in addition to tau deposition, lower cerebral perfusion or lower cerebral blood flow has also been shown to associate with normal aging, cognitive dysfunction in Alzheimer's disease, as well as cognitive decline in preclinical AD, represented by cognitively normal older adults. An image here on the left shows the tau PET data, so late frame SUVR really shows tau deposition for our young cognitive normal individuals, older cognitive normal individuals, and for AD participants. And we see that there's really no tau deposition in the two cognitive normal individual, but there is characteristic tau pattern in the Alzheimer's participant. And column figures on the right is the O15 water PET K1 estimate. So the radioligand delivery in the sea of O15 water, the current gold standard for cerebral perfusion. And we see that we see an aging as well as AD-related decline in cerebral perfusion estimated by O15 water K1. So the young cognitively normal individual has the highest cerebral perfusion or highest K1, aging-related decline in the second row, and then further disease-related decline in the Alzheimer's participants. And measures of cerebral perfusion may provide us complementary information on the individual status along the Alzheimer's spectrum, in addition to tau accumulation, which can potentially, again, improving our sensitivity for early disease detection or tracking disease progression. So in dynamic MK6240 acquisition, as I mentioned before, we acquire data for 2 hours after the time of injection. So here's a time activity curve for a Alzheimer's participant from 0 all the way to 2 hours after the injection time. And usually for our tau load, tau burden, we can use SUVR estimated over 90 to 110 minutes. So really within this little window in late frames scans. Whereas if you look at the early phase of dynamic MK6240 data, so really the first maybe 5 minutes or even 10 minutes, this early frame data or delivery phase of the radioligand from the blood into the brain tissue may contain important information about cerebral perfusion. And with dynamic MK6240 acquisition, this may allow us to assess vascular health, so cerebral perfusion and tau burden using a single dynamic MK6240 PET scan. So how do we measure perfusion measures using MK? So this is kind of like from the one slide intro on kinetic modeling. So the first measure will be the radial tracer delivery in this index K1. So that is the radioligand delivery rate from the plasma blood across the blood-brain barrier into the brain tissues. And if we have a reference region, we can estimate relative radioligand delivery index R1. So that is the K1 in a target region over the K1 in a reference region. So we have both the absolute delivery in the C and the relative delivery in the C if we have a reference region. And some previous literature on early frame PET. So previous studies have shown good agreement between the relative delivery indices or R1 of amyloid tracer Pittsburgh compound B compared to gold standard O15 water. And this is an example from the previous study in Alzheimer's participants for a O15 water relative delivery indice image and for a PIP relative delivery indice image. And a more recent study from MGH showed good agreement between the R1 of MK6240 and Pittsburgh compound B, the amyloid tracer, across cognitively normal and Alzheimer's participants. However, direct head-to-head comparison between MK6240 and our gold standard O15 water delivery indices has not been established. So in this study, we aim to examine if early frame MK6240 can be used to estimate cerebral perfusion. And to do this, we want to compare the MK6240 perfusion indices, so K1 with O15 water, and also ASL, so non-invasive way to measure perfusion. And also compare the relative perfusion indices of MK6240, so the R1 measures. And we really hope to further evaluate the feasibility of using early frame MK6240 as a surrogate for cerebral perfusion, so measuring vascular health and tau burden in a single scan. And also the suitability of simultaneously acquired MRI ALS as surrogate measure of PET perfusion, relevant for approaches using ASL perfusion to reduce the time required to perform reference tissue models, such as the simplified reference tissue model, where we still require the full dynamic, but we can use ASL to estimate early delivery. Potentially, we can only use a small subset of the dynamic acquisition to still get quantitative measures. So in this study, against performed on base 7 PET-MR, we have a relatively small sample size. So there are 17 participants in total. We have 4 young cognitively normal controls, 10 older cognitively normal controls, and 3 Alzheimer's participants. And all of the participants underwent dynamic MK6240 PET scans, and 11 of them underwent O15 water PET right before the MK6240 PET acquisition. And 15 of them underwent simultaneous ASL MR acquisition. So it was simultaneously acquired with the dynamic MK6240. And for regional analysis, we did regional analysis using the free surfer parcellations in target regions that are relevant for looking at tau burden. So in terms of our outcome measures, so for perfusion indices for MK, we have the K1 estimated from 2 tissue compartment model in 9 participants with arterial input function, so with arterial sampling. For O15 water is the same measure, K1, using 1 tissue compartment model, but with image-derived input function because we couldn't acquire arterial input function, arterial sampling during our water PET scans. And also for ASL is we estimate ASL perfusion. And for relative cerebral perfusion indices, we for MK, we have the R1, so K1 in a target region over reference region, and also SUVR over the first 3 minutes. And for O15 water, we have the R1 measures. And for ASL, we normalize ASL perfusion by the occipital lobe. And for PET measures, we use the eroded cerebellar gray matter as our reference region for relative delivery measures, because the extracerebral contamination that I mentioned before, the cerebellar gray matter is surrounded by the off target. So we erode it, trying to reduce that contamination. So if we look at the relationship between MK6240 K1 and ASL perfusion with O15 water K1. So across regions and participants, we saw that MK6240 K1 and ASL perfusion showed moderate to weak correlations with O15 water. And at subject level, there was a significant association between MK-K1 and water K1 across all participants, but not at regional level. There was no association between MK and O15 water at regional level. And for ASL, we have significant association at subject level in 7 out of 11 participants, And again, regional level, there was no significant association. And if we look at the bias of the MK6240K1 measures compared to our gold standard O15 water, for MK6240K1, we saw almost 50% underestimation. And so you see here is over 50% underestimation in MK6240K1 compared to O15 water K1, and also this negative proportional bias. So the higher K1 values, the more bias we see. And this 40 to 50% underestimation was also observed in the previous amyloid radioligand Pittsburgh compound B. And for AL's perfusion, we also saw this negative proportional bias and consistent with a prior O15 water Palomar study. And now if we normalize the perfusion indices by a reference region, now looking at the correlations with O15 water R1, so normalized by reference region, we saw strong associations across all regions and subjects. So at subject level, there was significant association for all subjects, and regional level, there was significant association across all regions. And for ASL, there's a moderate association across all regions and subjects. At subject level, there was association in 6 out of 11 participants. At regional level, there was a significant association in almost all regions. And how about the bias? So the bias in R1 was quite minimal for our MK6240 R1 estimate relative delivery. And this is, again, pretty consistent with the prior amyloid tracer where they saw that if we normalize it by a reference region, it really reduced the bias compared to O15 water. And for ASL, keep in mind, we use the occipital lobe as our reference region. If we normalize by occipital lobe, we saw that there's potentially 30% overestimation compared to O15 water. And the occipital cortex may not be the most optimum reference region for ASL, even though this region is deemed relatively spared in respect to hypoperfusion in Alzheimer's disease. Okay, so to quickly summarize this part of the talk, so our results show further support for the use of MK6240 R1 relative delivery indices as a reliable measure for potential relative cerebral perfusion across the Alzheimer's spectrum. And MK6240K1, on the other hand, so the direct absolute radioligand delivery may not provide reliable estimate of cerebral perfusion due to the large bias compared to O15 water K1. And ASL perfusion indices showed moderate correspondence with O15 water K1, but relatively higher intersubject variability, and normalizing by the occipital cortex resulted in significant bias, so overestimation in the ALC relative perfusion indices compared to O15 water R1. So overall, we think that using dynamic MK6240 acquisition, we can potentially get a measure of relative cerebral perfusion reliability, in addition to their tau burden. And there's some other work that's going on. You also using this Bay7 data. So this is work from Christina Louise on the retest performance of MK6240 tau burden and relative delivery indices in cognitive normal older adults using Palomar. And currently working with Maher, looking at the evaluation of multi-delay versus single delay ASL MR-based measures of cerebral perfusion using Palomar. Okay, so to move on to the K19IR00 project. So this is really work that's done in close collaboration with our MGH neurology colleagues, especially Doreen Rins, so who's a neuropsychologist at the Brigham. So the digital clock, the clock drawing test, the traditional clock drawing test on paper and using paper and pencil is one of the most commonly used cognitive screening tool in Alzheimer's disease. And a digital version of this test was recently developed to capture the clock drawing process, such as their thinking effort, how they're approaching the final outcome of the clock and the hesitations while drawing the clock, in addition to the final drawing outcomes of the clock on the page. And this thinking process can potentially capture more subtle cognitive deficits in preclinical Alzheimer's disease. And this digital clock drawing has captured the time-stamped pen, spatial pen coordinates of the drawing process with 12 millisecond temporal precision. So we actually have a digital pen with a little camera inside the pen to track the process of someone completing a clock. And a digital clock summary score was developed by MIT and Lahey Hospital, Randy Davis, who's also one of my Canadian mentor, and Dana Penny. Summary score was developed as a sum of some subscores targeting multiple cognitive domains, which I will go over in more details in the next slide. And this summary score was FDA cleared to aid AD diagnosis. So it's really pulling features that are potentially sensitive for AD diagnosis and combined into an overall composite score. However, this summary score, as I said, is really designed for diagnosis and is not designed for detect early pathophysiological changes in preclinical AD, which can be very different compared to advanced disease. We aim to identify novel digital clock composite scores that are most correlated with the underlying Alzheimer's disease pathology measured by neuroimaging. So here are the 4 cognitive domains that are captured by the digital clock diagnostic composite score. So there's the drawing efficiency, looking at the total time, the size of the clock, information processing, a lot of latency measures, so hesitation while drawing the clock. The simple motor, so really motor deficits, so maybe tremor, and that was designed for Parkinson's. Spatial reasoning, where the clock is placed on the page, where the numbers are placed within the clock. And you see here is an example of someone have very low digital clock performance. You see, in addition to the time, so they are on the same time scale, in addition to time, you see a lot of hesitation for this participant while drawing the clock, whereas on the left, you see a pretty smooth thinking process, a pretty smooth generation of the clock. So here's like a kind of outline for the K99 project. In aim 1 and 2, we will identify novel digital clock composite scores most correlated with tau and amyloid PET imaging. That's most correlated with cognitive deficits in preclinical AD. And in aim 1, we aim to use these diagnostic features that were previously defined by MIT and Lahey Hospital to see if these diagnostic features already capture underlying pathophysiology in preclinical Alzheimer's. In aim 2, we're going to go back to the raw data, start from scratch, design our own features using this digital clock drawing test that really show high correlations with tau or amyloid burden in this preclinical AD cohort. And in the R00 phase, we'll kind of expand our project to include other neuroimaging measures that are just not tau and amyloid, including MR-based measures of white matter high intensity, hippocampal volume loss, or perfusion measures from a dynamic PET or MR. And hopefully we can get a more, so we really want to further evaluate the digital clock performance in the context of clinical and biological heterogeneity along the preclinical AD spectrum. And using cross-sectional data during RAINS, a study led by during RAINS and KPAP showed worse performance in the spatial reasoning domain, so where the clock is placed on the page, is associated with high amyloid and tau burden in cognitive normal individual. And this is an example of someone drew a clock where not really utilizing any space on the page and the tiny clock in the upper left corner. And so for us, we wanted to look at the longitudinal change first, like can this test really detect longitudinal cognitive decline in this preclinical AD cohort? And we have, this is based on the Harvard Adrian Brain study. We have over 200 participants who are cognitive normal at baseline, who underwent tau imaging, amyloid imaging, as well as this longitudinal digital clock every year up to 5 years after their baseline. Just very quickly on the results, we saw that if a higher baseline amyloid burden was associated with accelerated cognitive decline in the overall digital clock performance, and also some cognitive domains really targeting the executive function, such as information processing. So that is a domain where it's capturing the hesitation or latency while completing the clock. Yeah, so here are some example latency measures that is in this cognitive domain. And similarly, for if someone has high tau burden at baseline, they also show accelerated cognitive decline in the same cognitive domain. So latency, more hesitation over time in the if they have high amyloid and tau burden at baseline. Yeah.
They were age-wise, they were comparable. Right?
Yes, they were. So all of these are cognitive normal older adults. So I don't remember the exact age, but we have it here. So age is 78 versus 79 on average. Yeah, so these are still some very preliminary results we're working on right now, but our preliminary results seem to suggest that longitudinal decline on this digital clock joint test, especially in the information processing domain or executive function or processing speed, is related to early amyloid and tau burden in preclinical Alzheimer's disease. And diminished longitudinal digital clock performance or worse performance over time, especially in these latency features uniquely captured by these digital tools, may reflect greater thinking efforts or cognitive deficits in preclinical disease. And as I mentioned before, we really currently we're hoping to move on to aim 2 and aim 3 of the project, really incorporating deep learning models to analyze the raw digital clock data from scratch, really develop our own features. What is the best feature that correlates with amyloid? What is the best feature correlates with tau or neurodegeneration using multimodal imaging? And there are a lot of activities going on with these digital cognitive assessment tools. So as there are several students are mentoring who presented their abstracts on the digital clock drawing test. But we also, in the same cohort, we have the digital maze drawing test that right now is led by Talia Robinson. So using the same digital pen, but completing a maze rather than drawing a clock. Is there more information completing a maze? Are we capturing different aspects of cognition compared to the clock drawing test? And we also have at-home cognitive tests. So that's led by other neuropsychologists at Harvard Aging Brain Study that's really looking at their short-term longitudinal performance because people can take that test at home. Okay, I think that's kind of a wrap up. Yeah, I think that's the end of the talk, and thank you for listening, and thank everyone at the Martinos Center for their collaborations and support.